Yep.
I'm an electrophysiologist at Albany Medical Center. We do a lot of clinical trials there, and I also volunteer as a chairman of the board for Aga Khan Health Board. That takes some of my time, and we'll talk about Barostim today.
And you're also the founder and CEO of a company, aren't you?
It's a remote monitoring company. Yes.
There you go. All right, thank you.
All right. So this is our. All right. So my alma mater, David from VCU, took some time. So I'll try to keep it under 10 minutes here.
Sorry.
And I ditto for David. I think everything you said about why do we care about our heart failure patients when they come to us, and sometimes we don't have answers to their exacerbation and all up until now. So we are in Albany. We have a very robust practice, 33 cardiologists, a few interventionalists. I just wanted to tell you about our volume here, and that's why we get exposed to a lot of patients. I've done some 17 Barostim implantations with a vascular surgeon. I want to acknowledge my surgeon there, Clem Darling, who's helped us a lot, and that's how we have gained our experience in this therapy. So the heart failure patients, when they come to us for ICD implantations and all, we know that 70% of these patients who receive the ICD have narrow QRS, and they are not eligible for CRT therapy. And 30% of those patients who receive CRT are non-responders. And as David said, that we don't take this term very lightly. So up until now, these are the patients who are in the hospital who are getting heart failure exacerbations, and we have nothing to tell them except take more meds, and we try our best to battle that with diuresis, etc. But Barostim has brought in new conversation, new life to this conversation in these patients with low ejection fraction. So these, again, repeating what the indications are here, that these are the patients who are NYHA class 3 or class 2 with recent class 3 events, EF less than 35%, NT-proBNP less than 1600, and they're not indicated to get CRT. So the electrophysiologist sees a lot of heart failure patients, as we know, and we see them in the settings of both outpatient as well as inpatient settings. And some of these patients are sent to us for an ICD implantation. They just know that ICD is going to fix their problems, their heart failure symptoms. These are the variety of patients who've either had a recent MI, have a new diagnosis of systolic heart failure, and they have lots of hopes for us that we're going to fix this by just an ICD implantation. And that's where we talk to them about the limitation of ICD implantation, that it can only protect your life and not fix the heart failure symptoms or improve their quality of life. So at this junction where we do the shared decision making, I believe that my practice is to talk to them about other therapies, advanced therapies like Barostim. And this is the junction when patient is actually the most attentive. They've had a big event in their lives, and they are listening to you very, very carefully. So not only I speak to them about an ICD, the limitations of ICD, but also that if they are eligible for Barostim, I talk to them about Barostim at that point. And I have had very good experience with patients being very receptive at that time. And if they continue to have these symptoms that makes them eligible for Barostim, we would go ahead and get Barostim implanted. CRT patients, non-responders, are a different group of patients. They're a special group of patients which we really try hard to give them the therapy they deserve and they're eligible for. But again, we have to optimize these patients. And if they still are having symptoms despite being on GDMT, I think these are the patients that should have a conversation with us about Barostim. I just have to, with my experience, I've noted that these patients are the sickest ones, and they have a very narrow window where you can get them from your consult to Barostim. if you don't have a good, robust system where you can get these patients very fast to the vascular surgeon, you may miss a window where they are now repeatedly getting either hospitalized or getting any other adverse events. Remote clinic these days, not only these modern devices not only gives us information on any arrhythmias, but it also gives us insight into some heart failure parameters like heart logic alerts, etc. So if you really dig deep into these patients and actually interview them thoroughly, 80% of these patients may give you some meaningful information, and you use your remote clinic for these patients and get them into a Barostim consult. And then don't forget your heart failure admissions and your discharges. We've had patients, we've been trying to, initially in the beginning where we were doing this pathway, we were trying to get these patients into a vascular clinic. They were repeatedly getting admitted in the hospital, so we would just call Dr. Darling's team in the hospital where they would get their consult, they would get their carotid ultrasounds, and then we will set them up for an outpatient implantation. So use your heart failure admissions and discharges efficiently. And again, on my transient or the team that takes care of post-discharge patients, they also get these patients very quickly into our office so that we can get them see a vascular surgeon. Again, CRT non-responders, we don't take this very lightly. We have to optimize them. Not every CRT implantation is done right. So, there are many etiologies why CRTs sometimes don't work. Suboptimal lead placements, your epicardial leads are not that as good as the endocardial leads, poor AV, VV synchronies. Ectopy, PACs, PVCs, they can all throw your BIV pacing away. So this is an example of a CRT non-responder patient who keeps getting exacerbations. And this is a sample of a heart logic alert. And this patient actually has clinically correlated heart failure symptoms. This patient actually ended up getting a Barostim and has not had any alerts so far in the last 4 months. So these are precisely the patients that have CRT implanted, and if they are implanted very optimally, they have optimized their medications. We've done everything possible, yet they're doing this, are the ones who we should talk about Barostim. We should think about this and also look into this further, how this group fares in the future. So let's quickly look at the study. This is one of our prized patients who, in fact, was our first patient, an 85-year-old gentleman who played pickleball before this event. He had bypass surgery, multiple PCIs. He had a sudden cardiac arrest, so we placed an ICD for secondary prevention. Basically, all the parameters that EF was less than 35, narrow QRS, NYHA class 2-3, he was on GDMT. So he was having recurrent events. His creatinine was going up because of diuresis, and we decided to talk. He was very, very excited to go back to pickleball, and it was not happening for him. So we took a chance, and we told him this is the indication, and this is a hope for you. We did a Barostim for him, and he did very well, thank God. He's doing very well. He's playing pickleball now. He's playing 9 games, he's telling me. I don't know how many 9 games, how bad that is, but it's pretty.
That's a lot.
It's pretty good. His family's very thrilled, and he wants to be now an ambassador for patients. So knock on wood, he's doing very well. This is his heart logic, his thoracic impedance over the last 3 months, and showed real good improvement in his thoracic impedance. Now, this kind of clinically correlated objective data makes our remote monitoring more excitable. Sometimes these kind of numbers gives us hope and enthusiasm. Case 2. This is an interesting case for 2 reasons, because of quality of life as well as some observations that I want to bring up So see if we can look into this in the future. He's a 75-year-old man with ischemic cardiomyopathy. He was on a wheelchair because he's now afraid to walk because he's short of breath all the time. His EF is less than 35%. He's on GDMT. He had narrow QRS, class 2, 3 NYHA. He's having some heart failure decompensations. So when we talked about ICD with this patient, I also talked to him about Barostim at that time. Already, I know that his ICD is not going to make a difference in his life except to protect him. So we discussed this, and he opted for it. So I was 8 weeks after his ICD implantation. We placed the Barostim, and somewhere around 8 weeks or so after his Barostim, he's doing very well. He's off his wheelchair, and he came in walking into the clinic. But he was also having some dizziness, lots of PVCs and PACs. And this is what I want to bring this up to you guys with our observation, that I'm going to use the highlighter here. So if you look at his PVC and PAC burden, around 65 days average was 11,000 PVCs a day, 3,000 PACs a day. This is his pre-implantation burden. Then his post-implantation, we reset all the counters, and within the first 10 days, or 7 to 10 days or so, his A pacing went up, his V pacing went down, and his PACs and PVCs went down 30%. This is just an observation, but is this some effects or negative dromotropic effects of reflex stimulation? I don't know. So something that we want to look at, something we want to see if this is actually a trend in PVC-induced cardiomyopathy patients. So with patient encounters, there is a thorough attempt to look at their quality of life. And we don't ask very open-ended questions like, are you short of breath? We have to ask more detailed questions of daily life and actually daily activities, like, can you walk to your car? Can you do your laundry? Can you go up and down the stairs? So very specific questions, and this is the form that my nurses use when we have our heart logic alerts at our remote clinic. So I talk to my patients about the limitations of ICD when I'm doing our ICD consults. I talk to them about it's just a tool to protect your life and not improve the quality of life. Then we talk about a Baroreflex, Barostim at that time. And I explain them that it basically is a tool or device that decreases the stress signals from your brain to your heart and increases the calming signals. And they all understand. One of the patients says, that sounds like a beta blocker to me. And it kind of is. So what do we do with the vascular surgeons after we are implanted? On the day we implant, we send them home without turning on the Barostim. And on the first week, we go up to 2 milliamperes, and we recognize if there is a stimulation a threshold, and if the patient can feel the pulsation, so we go below that. And then every 2 weeks, we go increase the milliamperes with the goal of 7 to 9 milliamperes. And then in 3 to 6 months, we follow up regularly. Again, in the end, if you're creating a pathways and you want to be successful, you do not create redundancies in the system. Empower your team to refer your patients directly to the vascular surgeons instead of everybody sending the patients back and forth to each other. That decreases the patient's efficiencies in getting to the vascular surgeon. Thank you.
All right, thank you.